Good morning. Welcome to Medicine Grand Rounds. It's my great pleasure to introduce our speaker this morning, Dr. Sunder Mudaliar. Dr. Mudaliar is a clinical professor of medicine here at UCSD in the Division of Endocrinology and Metabolism. He also serves as the director of the Diabetes Clinic and the Special Diagnostic and Treatment Center at the VA San Diego, and as a research scientist at the Veterans Medical Research Foundation. Dr. Mudaliar received his MBBS and his MD degrees at Stanley Medical College at the University of Madras in India. He pursued extensive postgraduate training, including a residency in internal medicine at the University of Rochester, and joined UCSD as a fellow in endocrinology, metabolism, and diabetes here at UCSD. We were fortunate to keep him here as a faculty member, and he has risen through the ranks. His research focuses on investigating novel agents and strategies for the prevention and treatment of diabetes. He serves as a co-PI on the NIH-NIDDK-sponsored multi-center diabetes prevention program outcome study, and is the San Diego PI for the NIH Epidemiology of Diabetes Interventions and Complications study. He is also the PI on numerous industry-sponsored trials and has published over 220 original peer-reviewed articles. We're so grateful to him to speak to us today on SGLT2 inhibitors, sweet success for the diabetic heart. Thank you, Dr. Mudaliar.
All right. Good morning, everybody, and thank you, Dr. Sim, for the kind introduction. First of all, the QR code is right over here. I've been told you can scan it and get your CME credit. It's indeed a pleasure and more so a privilege to present Medicine Grand Rounds. And my topic is SGLT2 inhibitors, sweet success for the diabetic heart. And this is not an original one. I took the idea from a nephrology editorial where they called it sweet success for the diabetic kidney disease. My conflict of interest disclosures are up there. I'm a speaker for AstraZeneca, but it's got nothing to do with this talk. And as Dr. Sim pointed out, I am a site PI on 3 NIH studies here in San Diego. I've been told to share something personal about me for a few minutes. Well, I thought I'd go to the start of my medical career. And actually, as soon as I finished medical school, I joined the Indian Army in 1978, more than 40 years ago. And that's me in my office dress, as it were. But that's me in my battle dress and in an undisclosed location. And this is an AK-47, a Kalashnikov rifle, which is unfortunately the favorite of many groups across the world. And it's a pretty lethal weapon. At this time, I was posted high up in the Himalayas in the far north of India on the border with China. And it's a place called Darbuk, 12,500 feet above sea level. Needless to say, it was very cold and not something I look forward to 40 years on over there. But every month we would go to this place called Pangong Cho. Pangong Cho means lake in the Tibetan and Chinese language. This is a lake at almost 15,000 feet, one of the highest lakes in the world, about 50 miles in India, 70 miles in China, 2 to 3 miles across. And although it's called a lake, it's salty. There's no life in it at all. And it is said to be the remnants of the lake when the Himalayas, which are fold mountains, moved against the Eurasian plate and carried the ocean with it over there. I also had an opportunity to go to a place called Daulat Beg Oldi, which still today is the highest airstrip in the world at 17,730 feet. And I've also met the pilot who landed an aircraft for the first time ever at that altitude. And for those of you who are aircraft aficionados, it was a US Packet Fairchild aircraft in those days. Well, after I left the Army, I did my post-graduation and then went to the National Health Service in England and worked there for 5 years, worked my way up over there. And my final post was in Derby, where I was just shy of being a consultant when, I got, the grass was greener across the Atlantic Ocean. I came to Rochester, New York, did my residency for a third time, and then I had the privilege to come to San Diego and be with my mentor, Dr. Robert Henry. As many of you may know, unfortunately, 2 years ago on New Year's Day, he passed away, but he taught me everything I know about clinical research. And he told me, Sundar, you don't want to be seeing patients day in and day out. You want to do clinical research. I have an ambitious agenda today, and my objectives are the following. I will first review the nature of cardiovascular disease and diabetes. And the classical view has been it's atherosclerosis. The vessels are blocked, mostly due to dyslipidemia, with contributions from hypertension, hyperglycemia. But the alternative view is that in addition to that, there is myocardial tissue hypoxia, inflammation, and oxidative stress. And these are people with clean coronary arteries. There's nothing wrong with the coronary arteries over there. And I will kind of focus on that in the context of my talk. I will discuss the effects of SGLT2 inhibitors and GLP-1 receptor agonists, which are two commonly used drugs in diabetes, and see what they do in cardiovascular disease. And I will make the argument that GLP-1 receptor agonists mainly act on atherosclerotic cardiovascular disease, the pipe as it were, whereas the SGLT2 inhibitors, they don't act so much on the pipe, maybe a little bit, but their main function, I will argue, is on myocardial function, on the pump, not the pipe. And finally, I'll describe the concept of therapeutic ketosis for the treatment of heart failure in diabetes. Type 2 diabetes is a very complex disease, and Professor DeFronzo from Texas has called it the ominous octet. There are defects in all these 8 organs, the kidney, the pancreas, liver, muscle, brain, everywhere it's there. That's the bad news. The good news is we have drugs to cover all of these defects in all these things. And let's not forget insulin, 100 years old today, and all of them lower blood glucose levels. But tight glucose control, this is kind of like the interesting part, improves microvascular complications, but really has no effects on cardiovascular disease. And that's a little unfortunate, because one of the definitions of diabetes from Miles Fisher from Glasgow is, he says diabetes actually should be defined as a state of premature cardiovascular death, which is associated with chronic hyperglycemia and may also be associated with blindness and renal failure. So the crux of diabetes, he says, is premature cardiovascular disease. It occurs perhaps 10, 15 years before people who don't have diabetes. But all these years till recently, we adopted a glucocentric approach, and that paid dividends in that it improves retinopathy without a doubt. Kidney disease, glucose control decreases albuminuria, a marker, but has no effect on progression to end-stage kidney disease. What about premature cardiovascular disease? Well, glucose control per se has got no effect on CVT. Perhaps as seen in the ACCORD study, there might be harm. In the ACCORD study, randomized placebo-controlled NIH trial was stopped 6 months early by the NIH because of the 26% increase, significant increase in all-cause mortality and cardiovascular mortality. Couldn't be explained, various things have been given, various reasons have been given. But when we talk of cardiovascular disease, what do we usually think of? Well, the classic MACE, as it were, major adverse cardiovascular events, MIs, strokes, and CV death. But I want to make the point that CVD is more than MACE. Heart failure is an important component of CVD, especially in diabetes, and even in women, as we found out recently. And my good friend David Bell wrote this 18 years ago. He said heart failure is the frequent, forgotten, and often fatal complication of diabetes. And in many populations, heart failure is highly prevalent and occurs in about 1 in 5 patients above the age of 65 years. And unfortunately, patients with both diabetes and heart failure have a poor prognosis. In some studies, a median survival of 4 years, worse even than some cancers. And unfortunately, not only is heart failure frequent, forgotten, fatal, it occurs early. How early? Well, we don't go looking for it in asymptomatic people, but this study from Italy at an academic center, it was called the short wave study, for what it's worth. They looked at a multi-center study in Italy, 386 people with type 2 diabetes, 5 years duration, and they did echoes on them looking for various parameters. These people had no evidence of inducible ischemia by stress testing. So you presume the coronary arteries are clean. What did they find? Nearly 70% of patients had evidence of LV dysfunction, 27% systolic, 16% diastolic, and 25% a mix of the two. So it's there. We don't go looking for it. It's not recommended that we do echoes on them. But if you go looking, it may be there. And once you have LV dysfunction, the natural progression is you're going to get heart failure or something, depending on the progression of the disease and other risk factors. So that's what we learned from the cardiovascular outcome trials, or the CVOTs as it is called. Now, let me remind you, the cardiovascular outcome trials were only imposed, as it were, by the FDA only for diabetes drugs after the rosiglitazone controversy. The FDA said any diabetes drug to be approved has to show cardiovascular no harm. So you have to power it for non-inferiority. It works, but we want to know it doesn't do any harm. And I will focus what they found, serendipitous findings of benefits actually with SGLT2 inhibitors and GLP-1 agonists. So for those who may not be very familiar, I'm sure most of the audience is, what are SGLT2 inhibitors? Well, just to reinforce, they work on the kidney. As you know, patients with diabetes, they take back most of the glucose instead of letting it go in the tubules. That is blocked, and they allow more glucose to go out in the urine. GLP-1 receptor agonists secreted by the L cells in the distal ileum, and they, of course, act on the pancreas. They increase insulin secretion, decrease glucagon secretion, tend to suppress the appetite, and also slow gastric motility. So what did we find out in the recent cardiovascular trials? GLP-1 receptor agonists, they have got MACE benefits, but no CHF benefits. Kidney benefits, yes, but reduced albuminuria. Until today, no effects on progression to end-stage kidney disease as a primary outcome. The studies are being done. SGLT2 inhibitors, MACE benefits, and heart failure benefits. Renal benefits, decreased albuminuria and decreased progression to end-stage kidney disease, prevents you from going and getting dialysis or transplant. So these two, heart failure and decreased progression, as of today, differentiates the SGLT2 from the GLP-1 receptor agonist. So my contention is, and we wrote a review article in this, GLP-1 receptor agonists, their effects are anti-atherosclerotic effects on the pipe due to various reasons. Improvements in A1C, blood pressure, weight loss, lipids, anti-inflammatory effects. There are GLP-1 receptors on the endothelial cells, which could also play a role. SGLT2 inhibitors, on the other hand, have effect on the pump, the myocardium. And I won't be talking about the kidney much, but everybody calls the kidney a filter. That's the glomerulus. But the main part of the kidney, which does most of the work, is the tubules. And that's a pump, multiple pumps going on over there. And the other point which we learned serendipitously in the CVOTs was heart failure benefits occur very early. How early, you might ask? Well, this was first seen, again, serendipitously in the EMPEREC outcome trial, which, what did it show? It was powered for non-inferiority and showed superiority, 14% relative risk reduction in the primary MACE outcome of non-fatal MI, stroke, or CV death. But they said, let's look post hoc at heart failure hospitalization and CV death. What did they find? Time to benefit for hospitalization for heart failure Day 17, it became significant. Hazard ratio 0.10, 90% relative risk reduction. And these are people who didn't have heart failure that we knew of. About 10 to 12%, they didn't go looking for it. It was not part of the inclusion-exclusion criteria. All they wanted to do was show that empagliflozin is safe and doesn't cause cardiac harm. But look at this, fascinating. Time to CV death, day 59. These are people already about 85% on statins, on ARBs and all that. This is something which really fascinated me and made me go and look deep into this topic. After the statins, nobody has ever shown, and not at day 59. Since then, multiple studies have demonstrated consistent effects of SGLT2s on heart failure as a primary outcome. All those I showed you were secondary outcomes. Across the spectrum of heart failure, from HFrEF, HFmrEF to HFpEF. Reduced ejection fraction, mildly reduced, and preserved ejection fraction. Outpatients, hospitalized patients. Doesn't matter if you have diabetes or no diabetes. The first primary outcome study, heart failure, was the DAPA heart failure study. What did they show? Almost 5,000 patients with HFrEF, DAPA 10 milligrams, reduced worsening heart failure 30%, CV death 18%, all-cause mortality 17%, independent of the presence of diabetes. Similar results were seen in the EMPEROR-reduced study in those with and without diabetes. Reduced ejection fraction. What about people with preserved ejection fraction? Well, this was the EMPEROR-PRESERVE study. Late last year, it was presented. What did they find? 6,000 patients nearly. Left ventricular ejection fraction, 54%. Empagliflozin reduced CV death hospitalization, 21%. Hospitalization for heart failure, about consistent, 29%. CV death was 9%, not significant, and also slowed progression to end-stage kidney disease. But those are all patients with chronic heart failure. What about effects in patients with acute decompensated heart failure? Those who are in the hospital. These people come in all the time, and we know heart failure is a bad prognostic sign, and these people keep coming back again and again. This was the first study. It was called the MPulse study, and I just picked it up yesterday. It was published 3 days ago on 28 February in Nature. And it looked at empagliflozin in patients hospitalized for acute heart failure across the world. 5 patients with acute heart failure, empagliflozin treatment after stabilization. You had to be stable, and they had parameters for that. Significantly improved. The primary composite outcome was death, time to heart failure event, and change from baseline in the Kansas City questionnaire, which is a symptom questionnaire. And this is very important, validated by the FDA. We all treat to, your ejection fraction improves, your this. But what about the patient? The patient has to say, yeah, I feel better. And if you improve the score by about 4 to 5 points, that's clinically significant. So they looked at that all after 90 days. What did they find? Now, this was a very complicated study. Remember, it was done across the world, multiple endpoints. And this is the first time the statisticians among you might know it. They looked at what is called the stratified win ratio. They do win, lose. Anyway, it was 1.336, which meant that patients on empagliflozin were 36% more likely to see clinical benefit at 90 days. All-cause mortality reduction by 50%, 4.2 versus 8.3. That's significant in my mind. Any heart failure event, about 50%. This is 10.6 versus 14.7. Improved heart failure score, 4.5, which is considered to be clinically significant over there. And again, these were people with HFrEF, HFpEF, HFmrEF, didn't matter. You had acute heart failure, you came into hospital. Didn't matter if you had diabetes or not. So this kind of begs the question, does hypoglycemia play such a role? That this drug is working in people without diabetes. And I'll come to that. Safety is very important, especially in acute heart failure patients. And remember, these people were stabilized before they got onto the study. AKI less, EMPA 7.7 versus 12.1 in placebo. In this study, there was no TKA. But let me remind you that currently the inpatient use of SGLT2 inhibitors with acute decompensated heart failure is not approved by the FDA. Similar results were seen in an earlier study called the SOLOIST worsening heart failure study. Again, these people in hospital or within 3 days of discharge started on sotagliflozin, which interestingly is a SGLT1 and an SGLT2 inhibitor. And again, dual inhibitor. Similar benefits, consistent in those with preserved heart failure and reduced heart failure. So we're seeing a pattern over here. These effects are consistent across the class and in people with any degree of heart failure. But in my mind, this is what puzzled me 5 years ago. What is driving the cardiovascular outcomes so early? 17 for 90% reduction in heart failure hospitalization and CV death. This is in 2016. The Toronto group postulated various mechanisms. They said if you block the SGLT2 inhibitor, you got metabolic effects, glucosuria, hemodynamic effects due to natriuresis. Glucosuria causes a negative calorie balance. You're losing calories in the urine. About a 2 to 3 kilo weight loss in the EMPA-REG study. A1C, it was a active, placebo control, but people could use whatever drug they wanted. There was a difference of 0.3 to 0.5, but this cannot cause such profound benefits. Weight loss of 2 to 3 kilos, no. Blood pressure systolic 3 millimeters. Which study, if you reduce 3 millimeters, blood pressure study, any drug cannot cause such profound benefits so soon. Now, plasma volume, you might say, but no diuretic so far has done that. And it's about 7%. And let me remind you, this is only seen at 1 week. By 1 month, this volume deficit cannot be picked up by current measures that we have, because the renin-angiotensin-aldosterone system resets the whole thing and your plasma volume is back to normal. Yes, changes in tubular glomerular feedback like with ACEs and ARBs can do it, but 80% of people already on it. So this is above all that. All of this individually could benefit the heart and the kidney. And also the sum of all this could explain the MACE and the CKD benefits. But I don't think this can benefit the heart failure and progression to kidney benefits, which occur early. The CKD benefits I haven't shown you, they take about 6 months to do it, but that's still pretty early. Heart failure within literally weeks happening. I think this can be explained by improvements in myocardial and renal tissue hypoxia. That changes in a minute, it can do it. So let me explain how. We put our hypothesis in 2016 over there, and we called it, can a shift in fuel energetics explain the beneficial cardiorenal outcomes in the EMPA-REG outcome study, a unifying hypothesis? Believe me, I made up this word fuel and energetics. I put it together. If you Google it, you really won't find it except this article. I just put it together. We said that the cardiorenal benefits are due to a shift in myocardial and renal fuel metabolism away from glucose and fat oxidation, which in the setting of diabetes is inefficient, and SGLT2 inhibitors shifted towards an energy efficient superfuel like ketone bodies, which improve myocardial and renal work efficiency and function. Now you might say, why should the diabetic heart and kidney become hypoxic? The heart is full of blood, it's pumping blood. The kidney gets about a quarter of the cardiac output. Why should it be short of blood and oxygen? Well, let's look at the oxygen consumption. The resting heart consumes about 8 ml per minute per 100 grams of tissue. The kidney is not far behind, 5 ml per minute per 100 grams of tissue. The brain, 3 ml per minute per 100 grams. Now, of course, we've got 1,500 grams of the brain versus 2 to 300 grams for the heart and the kidney. And the heart, when you're running, about 70 ml per minute per 100 gram of tissue. Now, what is this oxygen required for? So a very layperson thing will be to burn fuel in the mitochondria. But actually, if you go to look at it, oxygen doesn't burn fuel. Oxygen is actually an electron carrier. That's all it does in the electron transport chain. But it's important. And when you burn the fuel, as it were, in the mitochondria, you want an efficient fuel. How is that measured? We measure it by what we call the PO ratio. How many moles of ATP do you get per atom of oxygen consumed in the electron transport chain? Something like miles per gallon. One car gives you 50 miles per gallon, another one gives you 20 miles per gallon. Glucose by far and away the best fuel. For each atom of oxygen consumed, you get 2.58 moles if glucose is the fuel of ATP. Fat is more energy dense, palmitate 16 carbons compared to 6 carbons in glucose. You get 2.33. It's only about 11% less, but you might say that's not important. But remember, the heart beats 100,000 times each day, beat to beat, minute to minute. It makes a lot of difference. The heart, which is about 200 grams, consumes about 6,000 grams of ATP per day. So it makes a difference. Beta-hydroxybutyrate, on the other hand, is pretty close to glucose, 2.50. So fuel metabolism in the diabetic heart, why is it inefficient? Because there's metabolic inflexibility. The heart has to find a fuel every minute. It cannot stop for a minute. Well, in the diabetic heart, there's decreased glucose oxidation. Why? Because of insulin resistance and, of course, Randle's cycle. And increased fat oxidation because there's more fat. Randle's cycle says that in the mitochondria, only one acetyl-CoA can get inside. And if fat is the fuel, for some reason, glucose doesn't get it. Fat oxidation is energy inefficient. It's more energy dense, but it's got a less PO ratio, as I told you, less moles of ATP per atom of oxygen, relatively more hypoxia. And I did not realize this until really recently, fat is a dirty fuel. You get more reactive oxidative species because there is leak of protons in the electron transport chain. And this is one of the reasons the brain does not like to use free fatty acids, because the brain is a closed compartment and it cannot deal with quenching the reactive oxidative species. That's why the brain wants glucose or ketones. It doesn't like fatty acids. And in diabetes, there is paradoxical starvation amidst plenty. There's plenty of glucose, you can't use it. There's plenty of free fatty acids, you use it. It really isn't efficient. And this leads to a lot of changes in the heart, remodeling, dysfunction, decreased efficiency, and more progression to heart failure. And Stephen Neubauer, many years ago, called the failing heart an engine running out of fuel. Could ketones help? This is George Cahill, who's written, he's one of the pioneers of ketone body and fuel metabolism. He called it, ketones are a super fuel, more efficient to produce ATP than glucose or fatty acid. So this is a cartoon. In the diabetic heart, as I told you, there's more fat, less glucose oxidation, and of course, your PO ratio goes down because fat is being burnt. There's more reactive oxidative species, less efficiency of the heart, less contractility, more incidence progression of heart failure, and the heart literally struggles to breathe. What about the non-diabetic heart? Remember, I told you there are benefits in there. Paradoxically, in the non-diabetic heart, now this is a very complex subject. The studies have been done even in humans. There is less fat oxidation. There is less glucose oxidation. People who get heart failure, progress to it, they have very complex changes, including insulin resistance. But then you might say, if the heart is not burning fat or glucose, what's it doing? Well, it's doing glycolysis. It's doing it anaerobically. So, but this is fuel inefficient. For each mole of glucose, you get only 2 ATP instead of 34. So you're working harder. If you add an SGLT2 inhibitor in diabetic and non-diabetic heart failure, ketones are mild hypoketonemia in most people. I'm not talking about DKA. It doubles baseline levels. If you're 0.2, it goes to 0.4. And we know that ketones can be extracted and it can be oxidized. Ketone body oxidation, this has been shown even in humans. It tends to suppress fat oxidation, which isn't really good, and may or may not suppress glucose oxidation. The data is kind of a little murky over there. But we do know it improves the PO ratio, it decreases reactive oxidative species, improves the efficiency of the heart. Heart is now pumping better, less progression of heart failure, and the heart beats better. Now, we put this there, theory out, a postulate, and we thought, yeah, we're good. But within 1 week, this is cell metabolism. I could never hope to publish it. The group from Toronto, Gary Lopez-Chuk and Subodh Verma, they're good friends of mine. They said, not so soon. They said, a recent hypothesis, and they called me out by name. And they said, propose that increased ketone oxidation contributed to the effect. But several caveats indicate that the role of myocardial ketone oxidation is far from clear. And over the years, this is 2016, just 1 week after we published our hypothesis, which was well received. And I have to tell you today, it is in the top 5% of articles cited in Google Scholar and even PubMed. It's close to 400 citations in the last 5 years. But anyway, just in December last year, December 2021, there was this paper in Diabetes. Empagliflozin treatment is associated with improvements in cardiac energetics and function and reductions in myocardial cellular volume in patients with diabetes. They did 18 patients with type 2 diabetes, A1C around 8. They did cardiac MRI, where you can look at cellular volume. They also did P31 MRI spectroscopy, where you can look at phosphocreatine to ATP ratio over there before and after 12 weeks of empagliflozin treatment. For want of time, I can't share the full details. They cited our paper and they said empagliflozin ameliorates the cardiac energy deficient state, regresses adverse myocardial cellular remodeling, and improves cardiac function, offering therapeutic opportunities to prevent or modulate heart failure in type 2 diabetes. So this I thought was, this is in humans. They had control subjects and everything. So I think, is it the only thing? But no, but this is kind of very supportive of the hypothesis. But in the years since we wrote that paper, I said, can fuel energetics alone explain? These benefits are profound. Is it just fuel energetics alone? Well, growing evidence suggests that beta-hydroxybutyrate is more than an efficient fuel source. And this is a paper in Cell from Peter Crawford's group in Orlando. And he titled it Multi-Dimensional Roles of Ketone Bodies in Fuel Metabolism, Signaling, and Therapeutics. I didn't know this, but beta-hydroxybutyrate actually is not a ketone. It's grandfathered in as a ketone. It doesn't have that C double bond O, which acetoacetate and acetone has. It's actually technically a monocarboxylic acid. Anyway, it's got receptors in the cells, and through those receptors, it can act through the NLRP3 inflammasome, nod-like receptor protein 3, and it blocks inflammation in all kinds of organs. And this may be the benefits, part of the benefits over there. It acts through the hydroxycarboxylic receptor 2, GPR109, and blocks lipolysis. This may be a feedback loop. It acts through the free fatty acid receptor 3. It lowers metabolic rate, which is always a good thing. It acts, this is fascinating, histone deacetylation, which is very profound effects. And through FOXO3, it improves stress resistance over there. And through various mechanisms, as we know, across species, from worms to non-human primates, it increases longevity. Ketone bodies, but what I mean is that if you fast, about 30% reduction in caloric intake across species increases lifespan by up to about 30%. Very difficult to do the studies in humans, and it's presumably mostly due to beta-hydroxybutyrate. So now the hypothesis has expanded. This is from Gary Lopez-Chuk, a good friend of mine now, actually. He's in Canada. He said SGLT2 inhibitors, and this was actually in JACC Basic and Translation Science. I don't expect you to see all the things, but he says SGLT2 inhibitors work on the heart, the kidney. Finally, people are coming to the heart and the kidney, which we first postulated 5 years ago. The vasculature, the whole body, various effects. You don't really have to see that. But I want to postulate now that beta-hydroxybutyrate per se has got independent effects on energy metabolism, NLRP3 inflammation, improve remodeling, decrease ischemia, reperfusion. There's animal studies, there's some preliminary human studies. This is interesting. At the mitochondria, improved autophagy and lysosomal degradation, decreases oxidative stress, improves energy metabolism in the kidney. Very preliminary data, some in humans. Decreases inflammation. This has been shown in humans as well. Decreased blood pressure is well known. Inhibits the sympathetic nervous system. Preliminary data in humans. Increase erythropoietin. And that's fascinating. And I'm with one of my colleagues, I'm writing a paper on why it is increased erythropoietin, which is fascinating. All of this decreases the severity of heart failure, and I would say renal failure as well. I didn't address the million-dollar question. Why should there be ketogenesis with SGLT2 inhibitor treatment? It's causing glucosuria. It's a diabetes drug over there. No other drug causes ketoacidosis. I mean, it rarely can cause. Metformin doesn't do it. GLP-1s do it. What is the reason? And I went looking, and we published this when we did our paper. People call it pathological at that time. And we said it's physiological adaptation in fuel metabolism due to continued loss of glucose, an essential nutrient in the urine, even in the fasting state. Think about it. We eat a glucose, we use it, we store it in the liver, we use it, then we switch to fat. But if you're going to be leaking glucose all the time in your kidneys, you're going to be eating all the time. Otherwise, your glucose will fall to from 90, 50, could fall to 0. You just got to keep chugging glucose. You can't do that. So how much glucosuria? You'll be surprised. In an average diet, the average American diet is about 200 to 225 grams of carbs. With SGLT2 inhibitors, you get about 100 grams of carbs, which is going out in the urine. That's a substantial amount. If you don't have diabetes, your fasting is about 90, you get 50 grams. And if you have renal failure, it goes down to about 20, 30 grams, but you will get glucosuria. And that is an essential fuel. The body cannot afford to lose an essential fuel going out and being wasted. So what does the body do? It upregulates the SGLT1 transporter, which is distal, and that picks up about 50%. It doesn't have the capacity to pick up all the glucose. So picks up, we still get about 100 grams there, and then the liver turns on glucose production. Why? Because you have to supply tissues with glucose, the ones which cannot use fatty acids, and that the red blood cell, I didn't know this until recently, no nucleus, no mitochondria, it can only do glycolysis. The red blood cell, sitting next to it is the platelet. Platelet doesn't have a nucleus, but it's got mitochondria because the platelet does a lot of things. I think nature intended the red blood cell, you are carrying the oxygen. I don't want you to use it while you're going over there. I don't know how much you're going to be delivering at the other end. It's fascinating to see the metabolism of the red blood cell. The inner medulla of the kidney can only use glucose anaerobically. Why? Because the PO2 is around 10 to 15 millimeters. When we breathe the air in, it's 160 millimeters at atmospheric pressure. And in the blood, it's about 98, 99 millimeters of mercury. You can't do oxidative phosphorylation at this. And the CNS and the brain, before they switch to ketones, takes about 36 hours for them to ramp up their machinery over there. What about the other high-use consumers, the muscle, the heart, the kidney? Well, the liver says, I'm going to make ketone bodies for you and give it to you to use over there. Paradoxically, in humans, only the liver can make ketones, substantial amounts. There are small amounts elsewhere, but the liver cannot use it. It lacks the enzyme to use it because otherwise it would be a futile cycle going round and round. So with SGLT2 inhibitors, there is chronic, low-grade, mild hypoketonemia, approximate doubling of fasting ketones. If you have diabetes, it goes fasting, 0.3 to 0.6. If you don't have diabetes, 0.15 to 0.3. It's a small amount. And beta-hydroxybutyrate is about 75% of the total. And we wrote this in our paper, and one of the reviewers actually told me to add it in. We made the analogy that SGLT2 inhibitor treatment in humans is akin to the state of accelerated starvation of pregnancy, well studied in the 40s and 50s. Why? The fetus is mainly glycolytic. It has no fatty acid oxidation machinery over there. So the fetus is consuming glucose. Think about the mother feeding the glucose. That's why the mothers have to keep eating a lot. And because otherwise they become ketotic. What can they do? The glucose is leaking out, and it's an essential fuel, and ketosis is not really good for the fetus. So it is getting it. And it's fascinating. In the first 2 days after the birth, the fat oxidation machinery is ramped up. The fetus uses what little fat it has, and that's why the infants in the first week lose weight. That's the fat. And the mother's milk in the first 2 days, there's no lactose. It's all immunoglobulins, very little lactose. So the fetus then ramps up its fatty acid oxidation. All right. So given all this, with one of my colleagues, Pritika Ekanaike, who was a fellow then and is now an attending, we wrote another article that just published this January in Diabetes, Obesity, Metabolism. We said, we now want to propose a novel hypothesis linking low-grade ketonemia to the cardiorenal benefits. We said now, there is now evidence that in addition to being an efficient fuel substrate, ketones also impart anti-inflammatory, antioxidative benefits. They also have positive effects on mitochondrial biogenesis and function, erythropoiesis, and through that they ameliorate the pro-inflammatory and hypoxic milieu in those with heart or kidney failure independent of hyperglycemia. We propose a novel hypothesis to link the pleiotropic effects of low-grade ketonemia to the cardiorenal benefits seen with SGLT2 inhibitors. So if my hypothesis is correct, if beta-hydroxybutyrate per se has it, will therapeutic ketosis work? What's therapeutic ketosis? Well, if you get the ketones up to about 0.5 to 2, remember I told you it's about 0.2, 0.3 in the fasting state. After feeding, it goes down because insulin suppresses ketogenesis. And this is attracting attention in the cardiology. Literally, Daniel Kelly is a good friend of mine, and he's now back at UPenn actually. He wrote about therapeutic ketosis, and this is from his paper. When we give SGLT2 inhibitors, it's endogenous ketosis over there. And in patients with diabetes, heart failure patients, there are improvements in multiple myocardial parameters. And in the studies I showed you, DAPA heart failure, Emperor, Soloist, decreased heart failure hospitalization, and in many studies, decreased cardiovascular mortality. But what about exogenous ketosis? Why can't we give the ketones? Let's give a salt, a beta-hydroxybutyrate infusion. Limited data in heart failure patients. And first study was Nielsen et al. Published in Circulation in 2020. They gave one IV infusion of beta-hydroxybutyrate. Profound effects. Cardiac output went up by 2 liters per minute. Myocardial function and all changed. There was an increase in heart rate, but it had beneficial hemodynamic benefits without impairing myocardial energy efficiency. And these benefits were seen in the physiological range of BHOB. There are studies also in healthy participants, but I don't have time to go into it. But what about giving exogenous ketones by taking it orally? Well, the studies have been done, and I'll show you a couple of results later. It's mostly been studied in healthy people and athletes. Tour de France, guess what they use? Ketone drink. The British people who did. It is accepted by the World Anti-Doping Agency. You cannot take erythropoietin. You cannot take testosterone anabolic. This is allowed. Let me tell you, the patent for this ketone drink is held by Oxford University and the NIH and Department of Defense. It actually came out of one of the DARPA projects. People who know what DARPA is, it's a defense agency. Anyway, what are other methods of getting? And this was a recent article in Cardiovascular Research. And he says you don't have to do just be a ketone ester. You can go on a ketogenic diet diet, and I know Pam Taub here at UCSD has done a lot of work on intermittent fasting. The advantage is you can lose weight, HDL goes up. Disadvantage is very difficult to adhere to. You may deplete your glycogen stores. There's some risk of dyslipidemia. Cost is relatively low, but you get a whole day, or if you're doing intermittent fasting, half the day you get ketones, but very difficult to keep up with it. You have to have bacon and cheese and eggs for breakfast, lunch, and dinner, whatever. Or you could do intermittent fasting. MCT oil. This is something which is now my next research project is medium chain triglycerides. As you know, they have a favorable path in the body. They don't go through the thoracic duct and the lymphatic duct and come in. They go straight. So if you have C6 to C12, 12 carbon chain, you go straight to the liver, and they have a preferential pathway to become ketosis, and it works. Trust me. That's why there are many people now, for Parkinson's disease, they take it. For Alzheimer's, they take coconut oil. The advantage is it preserves glycogen, but you might lose fat mass. There's a risk of dyslipidemia, adverse GI side effects. But now it turns out that coconut oil has got mostly C12, which is lauristic acid, and that's got nothing to do with it's C8, caprylic acid, which is the active moiety of it. C8, C6, capric acid is it gives a very offensive taste. But anyway, the cost is coming down, and if you take 3 teaspoons of it, your ketones stay up for about 3 hours. Beta-hydroxybutyrate, I told you about the IV. You can take the salt of it. You keep your glycogen, no acidosis, huge sodium load, very difficult to digest. Cost is low. And if you give it IV, the duration is about 2 to 3 hours. Oral, depending on the dose, 3 to 4 hours. This is the new thing, the ketone ester. It is a drink. Disadvantage, it's got a bitter taste, adverse side effects. The cost is extremely high because I told you it's patented, and the duration of ketones is about 3 hours. Bottom line, you don't have to go on a low carb diet, which is about 50 grams a day, or intermittent fasting. You can get therapeutic ketosis by taking an oral ketone drink. But what does it do in heart failure patients? What's the evidence? Well, this was published last year, myocardial ketone body utilization in heart failure. And these people studied 9 controls, 19 HFrEF patients. Bottom line, acute nutritional ketosis enhances beta-hydroxybutyrate in extraction in HFrEF compared to controls. And this correlates with degree of cardiac dysfunction and remodeling. There are beneficial effects early days. But David Kelly's group, is not David Kelly. This is the group from England. They just published this in November in the Journal of the American Society of Cardio. They looked at healthy subjects. Remember, I told you, in athletes, it does a whole bunch of things. They're taking it. And they studied 20 healthy people. They gave them the ketone ester, and they found multiple beneficial effects on stroke volume, ejection fraction, the global longitudinal strain, everything. And multiple beneficial effects on myocardial function, other hemodynamic parameters in healthy adults, similar to that seen in heart failure patients. Heart failure is a very complex disease, and you have various flavors, HFpEF, LVF more than 50%. And if you look at guideline-directed medical therapies, only 2 class 2B indications, ARBs and MRA. HFmrEF is kind of like the orphan child in between. And now the decision by the powers that be is it should not be called mid-range, it should be called mildly reduced ejection fraction. Again, as of today, 2 class B recommendations, ARBs and MRA. HFrEF, LV ejection fraction less than 40. We've got 5 class 1 recommendations, ACE, ARB, ARNI, which is angiotensin receptor, neprilysin inhibitor, beta blocker. Great. And 2 SGLT2 inhibitors have been approved by the FDA, DAPA and EMPA. And December last year, the FDA, this is very odd, they endorsed the use of sacubitril valsartan and ARNI and spironolactone in those with LVF. Look at the language, less than normal. That's patients with HEMREF and HFpEF. So ARNI comes into the picture. And just last week, the FDA approved empagliflozin based on that EMPULSE study, on the HFpEF study, regardless of LV ejection fraction. So do the SGLT2 inhibitors cover the full range of heart failure? We've come a long way in 100 years. 2016, this is Elliot Jocelyn, and the father of diabetology in the United States for sure. He used to treat his patients with a keto diet. I've given grand rounds in endocrine, and it's fascinating how he treated his patients. He kept detailed records of it. 6 years later, we got the discovery of insulin, and this is one of the original vials from the University of Toronto. Let me remind you that the patent for insulin was sold. In those days, it was considered unacademic, unscholarly to patent your discoveries. But the university told them patent it, so it was patented for $1. So the three guys, $3 sold to Eli Lilly. I have a copy of the patent if it's available online. Anyway, 90 years later, we got the SGLT2 inhibitors, and Michaela Demand said, SGLT2 inhibitors for diabetes, turning symptoms into therapy. People said, oh my God, you're going to kill the kidney. But that's not what happened. And then after the DAPA heart failure, guess what? It's not a diabetes treatment, a novel cardioprotective therapy that also improves glycemia. New England Journal is pretty sedate. They also said cardioprotection with yet another SGLT2 inhibitor, an embarrassment of riches. And this really blew me away. JAMA Cardiology, could flozins be the statins for risk-based primary prevention of heart failure? But in my opinion, I think SGLT2 inhibitors have introduced a paradigm shift, not only in diabetes management, but also in the management of heart failure. CKD I didn't talk about. I think it's sweet success for the diabetic and non-diabetic heart and kidney disease. And these, in my opinion, are at least partly due to changes in fuel energetics over there. Will exogenous therapeutic ketosis also have similar benefits? I don't know. Time will tell. So let me finish with this quote from Kalidasa in the one of his plays, Malavika Agnimitran. Kalidasa is widely regarded as the greatest poet and dramatist in the Sanskrit language of India. And apparently Sir William Osler and Johns Hopkins kept a copy of his poem on his desk. What did he say? Do not accept anything as good just because it is old. Do not reject anything as useless just because it is new. The wise weigh the substance and decide for themselves. It is the unwise who are led by the opinion of others. And so please use the QR code below to claim questions. And I couldn't help adding Voltaire, the famous 1700s French philosopher. His real name was François-Marie Arouet. He said, judge a person by his questions, not by his answers. Thank you for listening to me.
Dr. Mudaliar, thank you for that really extensive and very compelling presentation. We have a few questions from our audience from Dr. Agarwal. Excellent lecture, loved it. Let me ask, are the mechanisms for benefit different for chronic and acute heart failure?
Well, the honest answer is I don't know. So it could be a mix of it. It's not diuresis. We know that for sure. It's not the plasma volume. Nobody has ever measured ketones, so I don't know. But let me tell you, I didn't have time to do it. There was a study called the DARE-19 study, which was started during COVID last year in April. And guess what the drug was used? They used it in COVID patients in the ICU with certain parameters, dapagliflozin. But by the time it started in March, April, we were using remdesivir steroids, so their power came down. But there were many less deaths in the DAPA group versus there. Begging the question, was it an anti-inflammatory group? There are still some studies going on using a ketone ester in the Netherlands to see if it works. I haven't seen the results, but I don't know, honest answer.
Thank you, Dr. Mudaliar. From Dr. Sagu, what is the role of SGLT2 inhibitors in end-stage renal disease with heart failure?
Now, I don't know what by end-stage renal disease, I mean, I presume it's 0 to 15, which is stage 5. I think you're at the end of the road. It's time for dialysis or transplant. But this drug has been studied. I've given grand rounds to the renal people with an eGFR up to 20 in patients with diabetic and non-diabetic kidney disease, including people who had IgA nephropathy. It slowed the progression to kidney disease. But you have a very small margin. Does it work? Yes. But the later you are, the less, it is. But it does work. It does work.
Thank you. And from Dr. Borick, our chair, thank you for a wonderful presentation. Has this approach been used in, for example, lung or other fibrosis, where metabolic dysfunction of epithelial cells is an important contributor?
Wow, thank you for the question. I'm honored that our chairperson has testing it. That's a very interesting question. I never thought about it, and I will go looking for it. Thank you for drawing my attention to that. I don't know. There are no studies that I know of that address that question. But there's all this epithelial mesenchymal transformation in which take place in the kidney. I've looked at it, and now I don't know if macrophages are involved in the process, and I don't know. I presume they may or may not be. It turns out that the fuel for macrophages is not so much glucose as acetoacetate. And there is evidence in the liver, I don't have time to do it, that's a GI grand rounds, that in patients with cirrhosis and this thing, that in animal studies, if you give acetoacetate, it improves the function of and there's a shuttle going on, and it decreases progression to fibrosis. So that's a great question. Never thought about it, but I will.
Thank you. From Dr. Edelman, what screening tests would you suggest for our patients with type 2 diabetes? BNP, EKG, echo, stress echo, even in asymptomatic patients? Thanks.
Thank you. And I want to let the audience know that when I was a fellow, Dr. Edelman was my mentor. And I'm grateful to him. He taught me a lot of clinical medicine. So that's a very difficult question, and you've given me a wide range of options. As of today, there is really we don't go looking for something because we don't know the extent of the problem. EKG is as good as it gets. That's how we found out, oh, you had a heart attack many years ago. It may have been a silent MR. We don't do echoes. That will significantly push up the cost of our healthcare and everything. But I told you it exists. You go looking for it. What are you going to do about it? BNP is seeming to be, but we don't know where that cut is. Is it 100? Is it 40? What is coming into more prominence now is the high sensitivity troponin T, troponin I, and all that, because there could be small leaks from the myocardium, which doesn't approach what we are looking, of course, with our sensitive test. And there is epidemiological studies suggesting that they predict heart failure, mortality, and all that. But honest answer, I don't know. We should ask some of our cardiology friends that. I don't know.
Thank you. From Dr. Mohammed, thank you, Dr. Mudaliar, for this talk. You mentioned the concept of therapeutic ketosis and the fact that intermittent fasting can induce it. It is difficult to find grants funding investigation into the various types of intermittent fasting, perhaps because it is not a pharmacologic therapy. Any thoughts on how to accelerate the amount of research into intermittent fasting in its various forms?
I don't know where Dr. Mohammed is from, but Pam Taub is doing research. She has gotten funding. And tell me about the funding. I was rejected for 2 VA merits. I've just applied for NIH merit at the fag end of my career. And it was for a pilot grant because I don't have data. Let me tell you, I spent $1,000 of my own money. I bought the ketone drink. It's very expensive. It's $30 a day. How long do you take it for? I and 2 of my colleagues, we did it on ourselves. We bought the ketones. It works. It sends it. So my ketones 0.2, 0.3. I take the drink 1.82, but it lasts. If you take it, it lasts. I've tried the medium chain triglycerides. I don't get that much. It's about 0.8. But without preliminary data, nobody will fund us. If somebody has an idea, I would love to do it.
And from Dr. Parker, Do you have comments on SGLT2 inhibitor studies in cancer?
Those studies are there. That's not my field at all. Now, I have to tell you that the Warburg's phenomenon is that the cancer cells shift to anaerobic glycolysis. And actually, Warburg was one of the original people, he got a Nobel Prize sometime in the 1800s, who actually talked about ketone metabolism. And his student was Krebs, who also got the Nobel Prize for the Krebs cycle. Those people had already cottoned on that there is acetyl-CoA coming in over there. And Krebs trained a person called Richard Veitch, who just died a couple of years ago at the NIH, who was very in all these studies. So is there something there? For sure, there is something there. I don't know much about cancer metabolism. I do know it's anaerobic glycolysis. It does there. Are there studies going? I have not looked at it.
And one final question from Dr. Agarwal. Do you recommend using SGLT2 inhibitors early in patients who have high cardiovascular risk with or without diabetes?
All right. I can only go by the product insert and the indication by there. Now, the person has diabetes. You're welcome to use it as a first line. There is no prohibition on doing it. Cost is an issue, but in some parts of the world, and I know in India, that it's literally cents that you can get some of the SGLT2 inhibitors. I don't know, but somebody has to look at it longitudinally. I have no idea what it will do. Will it? In my opinion, yes, it would do great, but it's not approved for pre-diabetes. Although I didn't show you the data in the DAPA heart failure study. In that study, in addition to all its effects, it slowed the progression to diabetes by 32% in that short study, for what it's worth.
Thank you so much, Dr. Mudaliar. We're so grateful to you. I want to let our Grand Rounds audience know that we are launching a survey to get your input on the best day and time to have Department of Medicine Grand Rounds starting in the next academic year. Margaret has posted a link to the survey in the chat, and you will also receive an email. Please complete the survey so that we can get as much input as possible from as many of you as can about the optimal time for Department of Medicine Grand Rounds in the upcoming academic year. Dr. Mudaliar, again, thank you for this outstanding presentation. I look forward to seeing all of you next week at Department of Medicine Grand Rounds.
Can I say one more word? Sorry.
Of course.
I just looked at the chat box. Somebody asked, and it's a very rightful question, what about UTI in real world practice? UTI is numerically more. That's in the more issue is genital infections, which does occur more. But in most of the studies, and I've used it, you can treat through it. There are rare patients with recurrent genital candidiasis, and I would not use it in those patients. And Dr. Gass has given a comment about starvation and ketosis. Well, that's exactly what it was. Yeah. Sorry to take more time. Thank you.